Welcome all to our March edition of the TB Think Tank webinar series. And as a think tank last week, we had an insightful discussion, a meeting with scientists, researchers, and clinicians, which includes Dr. Genade, who had presented on the importance of keeping TB visible. And in this session, we bring in the civil society voices to share their perspectives on why keeping TB visible matters and how the End TB campaign is helping build public understanding. This session will be presented by three speakers. As you can see, we have Leisha, Genade, we have Dr. Zolelwa Sifumba, and lastly, we will have Russell Rensburg. And please do note, people, that all questions will be addressed at the end of all three presentations. And our first speaker for today is Leisha Genade. Over to you, Leisha.
Okay, good afternoon. Good afternoon, everyone. Are you able to hear me and can you see my screen?
Yes, we can. Are you going to put it in slideshow?
I'll do that.
Yes, thank you. Thanks.
Okay, thank you so much. So yes, good afternoon, everyone. So my name is Leisha Genade. I'm a project manager at PHRU, and I have been requested or asked to look at identifying and addressing bottlenecks in TB diagnosis at facilities. And this is taking it through from demand through to delivery. So just going into a little bit of, okay, so now it's not going through, sorry. Okay, is it moving through? Just making sure.
Yes, it did.
Thank you. Yeah, so tuberculosis remains a critical global health challenge, as you all know, and that particularly in like high-burden areas like South Africa. And so where earlier diagnosis is very essential in order to reduce the morbidity, mortality, and the transmission of TB cases. But despite this advances in diagnostic technologies that have been going through many years, there's still bottlenecks at healthcare facilities that continue to limit the efficiencies of the TB programs. And so epidemiological data have indicated that in South Africa, in about 2023, about 270,000 TB cases has been identified, which 56,000 deaths have occurred, and that's been documented in the TB recovery plan of 2025. And also globally, about 10.5 million have active TB and have been reported in the global TB report. So as countries scale up public-facing end TB initiatives, health facilities must prepare to manage an increased diagnostic demand. And this includes like the high throughput triage, testing, and patient management. Bottlenecks often arises, as you see there, common facility bottlenecks, which includes your staffing, patient flows constraint, weak data systems, sputum collection barriers, and poor TB-HIV linkage, TB linkage. And so, for instance, in many countries, and many facilities, the facilities still rely on symptom-based screening. And even though we know that there are evidence, as you can see, written by Dr. Brano, that about 55% of TB cases are those without symptoms being reported. And so diagnostic bottlenecks also stem from operational challenges that we've seen, such as the sputum collection difficult barriers and also inadequate services. And so ultimately, improving facility diagnostic efficiency strengthens the full TB cascade from demand through to delivery. I was involved in two studies, TAT Plus and TAT and TAT Plus. TAT was conducted 2019 to 2020, and we basically looked at prioritizing three high-risk groups for sputum testing, regardless of their symptoms. And this was to detect subclinical TB or to reduce misdiagnosis. It's been written up from Prof. Martinson in 2023 when it was published. And then a couple of years after that, we conducted the study TAT Plus 2024, 2025. And this was basically to look at the evaluation of a tongue swab, which is part of an integrated model, and see if we are able, with pathways, identify high-risk groups. But part of this study, we've also looked at facility readiness and operational flexibility. And this was basically to look at communications and having discussions and workflow with the facilities to increase, to look at the demand while maintaining the quality within the facilities. So I will say TAT Plus basically represents a paradigm shift from where it was traditionally being symptom to risk diagnosed screening. And not only within this, but there are many other studies that have indicated this. So this approach basically prioritizes high-risk groups. The high-risk groups are people living with HIV, recent TB contacts, individuals with a history of TB, and offering them sputum testing regardless of whether they had symptoms. And as I've indicated within the TAT Plus, where we have actually introduced the tongue swab. So while we were in the facilities over these, so with that, we were in about 60-30 intervention, 30 non-intervention. And in the TAT Plus study, we were in about 10 facilities and across 3 provinces in South Africa. And what we have looked at is identified there were some structural gaps in facility readiness. Uh, One of the gaps been identified was space and patient flow constraints. And the obstacle there was basically lack of adequate space, no clear triage points, patient dropouts due to lack of knowledge and stigma. And what we have seen with recommendations in facilities, well-organized layouts basically bear the fruit. Another gap that we've identified, part of structural, was sputum collection. And this was basically where there's a lack of private, dedicated, well-ventilated areas, or even the sputum samples that the participants have produced were somewhat poor and not ready for testing. And what we have then recommended at that time is to look at dedicated sputum booths, improve private areas, and then the one that we do also is, especially in participants or patients that does not have, that will not be able to produce sputum, an extended spot. So with structural, we also looked at patient flow. So we did quite a number of facility mapping in the facilities, patient flow. And what we have found also with patient flow and diagnostic bottlenecks, they were fragmented facility navigation. So from where they start off with screening, registration, screening, going through to sputum collection and test submissions, those were not very well coordinated in all of the facilities. I must say that some facilities already had very well structured plans in place, but not everyone. And so when that happened, then there is a delay and it also causes some congestion. Sputum bottlenecks and under testing. So on the demand sample production, it is difficult for asymptomatic patients to actually deliver sputum. So there were quite a lot of under testing, especially within the high-risk group, when patients were basically indicating that they are unable to produce sputum and then they will just go. Also with the group context and antenatal care, those were the I will say, the most neglected groups of high-risk patients that were tested. So symptom triage missed basically infectious cases, as we have indicated already, that about 55% of the TB cases are without symptoms. And so symptom-driven screening basically delayed some of the diagnosis and enabled transmission. So what stream models are we able to add? And we looked at if there's early risk stratifications, a direct routing for sputum stations, flexible options to improve detections and reduce congestions within the facilities. And this all through training and navigation tools. And the reason why I'm saying this is because there were quite a number of staff within the facility that were not very knowledgeable when it comes to TAT, or targeted universal testing. Although our criteria going into these facilities when we conducted these studies were that these facilities were known as TAT facilities. So they have been introduced already, but not all staff were always aware of this. Some systemic constraints was workforce gaps and role ambiguity. In some facilities, we found that there were few nurses, and few nurses, not necessarily less in terms of the number as such, but also those that were trained, because there will be a TB nurse, and if the TB nurse is absent, then there won't be any TB nurse. Counselors and data clerks that basically assist. So if there's an absence of any of the staff, it does cause a little bit of, I will say, role ambiguity, and also, smooth running of the facility. Their responsibilities were slightly unclear. There were slow specimen collection, poor data documentation, and follow-up. When you go through to the TB registers, when you basically look at how many people have actually collected sputum for the day versus how many was eligible for the day, that did not add up. It's either not being done or it has not been documented. We also saw a weak integration and contact tracing. There are facilities that had the integration of both TB and HIV, which was actually very good. But you also find facilities where there was still this disconnect between when the patient comes for his HIV, for his ART medication, where they were due for TB testing as part of either an SOP or as the policy already indicated, when should we test? And this led to some miss cases and also delayed detection. So optimizing facility operations. Let me just take this away. I can't see it. Sorry. Okay, I tried to get that away, but let me continue. Optimizing facility operations, basically when we look at strengthening TB diagnosis, we recommend prioritizing high-risk triage and screening. This is to speed up case finding, missing cases, and support participants that are unable to produce the samples. And workflow redesign and provider support. This relocates sputum booths to the nearest designated fast-tracked flag clients, and also reinforce with training. We have seen that for example, the contact tracing cards will be given out for contacts to come in, but the minute when they come in, they are not always fast-tracked. So they will go within the same flow as all the others. And so that can also be improved. Real-time data monitoring, like your track testing coverage that include the asymptomatic, it can improve on the turnaround time and readiness for scale-up. We also recommend an operational improvement, making sure that clarifying roles within the facility, who is supposed to be doing what, when, and should there be staff that are not there to support through task shifting and training of all staff. And then lastly, looking at system alignment and accountability. So we are aware that some facilities are aware of the policy of TAT, but the actual implementation within the facilities tend to be a bit poor. And so if the policies together with training and mentorship, this will, look at detecting more cases. Move. So in conclusion, we look at strengthening the pathway will definitely prepare us, prepare for a rising demand, fix the bottlenecks early, and integrate the HIV and TB linkage. So insights from the TAT and TAT Plus underscores the critical needs to address structural deficiency. It will optimize your workflows and deploy innovative screening tools to capture cases the traditional method misses. So as we are public-facing and TB campaigns now driven for this month being TB month, we need to drive greater awareness and testing and improve the testing demand. But we need to be prepared within the facility. And the only way that we are able to do that is to address the operational challenges that we're already facing within the facility. So facilities needs to be more flexible, having more flexible workflows. And it is possible. We've seen that through some of the facilities. Once we have made some of the recommendations, they were able to reorganize themselves within the facility to actually improve that. Sufficient staffing, I know that is an issue. It's a problem everywhere. Not people will tell you there's not always enough staff, but task shifting and also training everyone on board so that that gap does not exist. And then it just adequately prepare in terms of having strong data systems. Strong data systems is very important. And we've seen it. It was at times very difficult to get some of the information in terms of who is asymptomatic, who's symptomatic, unless we basically ask the participants. But stronger data systems for sure can improve. And so additionally, also integrating TB services within the broader health system function, which includes like your HIV care, antenatal service, as I've already alluded that those were found to be the most under-resourced group, basically. And also integrating into the chronic disease management. And I must say, these have been there. It's in the policy, it's in the guidelines, but the actual implementation within the facilities, this is where the problem arises. And therefore, I think that when we are able to look at sensitizing from the facilities, the community around, and looking at facility mapping in the facility, patient flow analysis, and also looking at the diagnostic bottleneck. And every facility is different. We are able to better forecast the needs for that specific area or facility. And I want to thank you very much for listening to me. And this is all the parties involved in TAT Plus in TAT study. Thank you so much.
Thank you so much, Leisha. Thank you for your presentation. And just a reminder, if you're just joining, our questions will be addressed at the end after all three presentations. And our next speaker is Dr. Zolelwa Sifumba.
Can I start?
Yes, you may.
Okay. Hello, everyone. Greetings from sunny KZN. Thank you so much, TB Think Tank, for having me today. And yeah, warm greetings to you all. My name is Zolelwa. Can I please have the next slide? So I will be speaking a bit on humanizing TB. And I think there is no better way to humanize TB than to tell you a story of a TB patient who became a TB survivor, who then became what I like to call a TB conqueror. I'm starting off with this quote that says, "This is a very key point in your life, how to transform a very negative experience to a very positive experience. It will give you a lot of power." And this is what my story is about. Can I please get the next slide? So I thought I would tell my story in a series of pictures. Yeah, my journey with TV is quite an interesting journey, but I will start off. In the corner there is little baby me, just a girl in the world, you know. And then I also have a picture of myself in high school there. And in high school, when the choice came to decide what to study, my father is a doctor. So I, was faced with a lot of us who are intelligent brown people, we're told, either go to medicine or law or engineering, or, there's kind of this list of things that you could do. But anyway, I was very interested in helping people. And when I got to matric, or rather when I got to grade 11, grade 10, I found human biology very interesting. And so I thought, okay, let's do this medicine thing. And then the other two pictures are of me in university before the TB. I was basketball player. Yeah, and I was just, a regular student, going about my regular student life. Please, can you go to the next slide? And then when I reached fourth year, I was actually diagnosed with clinical depression. I was studying, as I said, my fourth year. And yeah, I was depressed. I was anxious. We had just started doing our clinical rotations, which I think added to the pressure that I was under. So anyway, I decided to leave for the year to go get help. I was admitted into hospital, started on treatment, all of that. I came back in September of that year, just to get ready, to get used to going into the wards again. Yeah. So when I did start going back to the wards, I woke up one day with a lump on my neck. I told my friends about it. We had a great big laugh about it. One of the differentials was TB, but we're just like, nope, that doesn't happen to us. And then the lump grew, got bigger, so I had to go get it checked out. I went to the hospital. First, they did a fine needle aspirate biopsy, and they told me to come back if it got bigger or any more painful. It did get more painful, it did get bigger, so I came back. They did a fine needle aspirate biopsy after that, and a couple of days later, I think it was about a week or two, it was a weekend, I got a phone call. And on this phone call, I was told that I've got multi-drug resistant tuberculosis. I couldn't believe it. Yeah, I think I didn't believe it for the first couple of months. I was just like, look, they made a mistake. But anyway, I started treatment. I took 21 pills, and there was a really painful injection. And I just felt so upset, that I hadn't been warned about this thing. I didn't really understand where I got it from, but because I worked in a hospital and because a lot of our patients, well, I wasn't working at that stage, I was a medical student, and so we were clerking patients, and some of the patients didn't have the correct respirators on, so halfway through clerking, someone would tell you, oh, I was recently diagnosed with TB, and now your head is spinning, you already started this clocking thing, there's nowhere to find an N95 respirator, so you just keep going. Anyway, the treatment was horrible. It was horrible, horrible, horrible. And I was certain that if the TB didn't kill me, then the medication would kill me because I looked through the side effects. And if the medication wouldn't kill me, then I would kill myself. I had a plan to go to a train and just jump in front of it because I felt like I was dying. Yeah, next slide, please. So what happened then, I attended a session by an organization called TB Proof in the Western Cape. They came to my medical school, and for the first time, I saw someone who had multi-drug resistant TB, which was Deline. And I got so excited because at that point, I'm sick. I don't know anyone who's sick. I've read through all the side effects. Everything says I'm dying. Everything says I'm dying. And I was still trying to keep going to medical school, and it was fourth year. So we're doing clinical medicine, we're going up and down, and I have to walk to the clinic, and it was just a complete mess. But anyway, I met them and I got a family, I got a support system, and that support system was of other survivors and others who had TB, were going through treatment, that understood what I was going through. And so they could give me advice and they could be with me. And beyond that, they gave me the opportunity to share my story. So the first time I shared, I said I would come, but I said I wouldn't share. But I realized that the students weren't listening. And so I decided, okay, I'm going to get up on that stage. And I did, said hi to everyone. It was like, hi, Zoe, hi, hi, hi. And I was like, guys, I've got multi-drug resistant TB. The whole room was silent. And thus an activist and an advocate was born. And so while I finished my treatment, I did some advocacy work, but when my treatment was done and I went back into medical school, everything, I like to say everything made sense now. I wasn't just there for the textbooks and for the, for the glory of being a medical doctor. I was there as someone who understood the public health system, and I was an activist, I was an advocate, and I was part of civil society, but from there, I had a big desire to really understand the TB world. There's some pictures here. I took there's pictures of some TB proof work here. There's me graduating, me with my family. There was also a trip that I took to the UK as I blogged. I blogged with Doctors Without Borders while I was on TB treatment. And so when the treatment was over, they invited me over. So really my international TB career began, but I had this deep desire to understand the TB world because I saw all the different role players. I was there as a patient and a patient activist, but there were professors, there were people from research institutes, there were funders, so I decided that I want to understand all of it. Please go to the next slide. This signifies the point of my life when I was a medical doctor working for the KwaZulu-Natal Department of Health, as well as an international activist. So as you can see here, there's pictures of me as a doctor. There was a documentary that was released called Unmasked, We All Breathe, and it was about health workers who had experiences with TB. There was also an amazing time when I went to the Global Fund Replenishment Conference in 2019, and I was one of the faces of the fight for the Global Fund. So I added my voice to that fight, and they raised billions of dollars that day. So it was just so amazing to be part of the structure. But as a medical doctor, I was treating all sorts of people with all sorts of illnesses, but now I was treating people with TB. So it's like I was on the other side now, experiencing the issues within the system, within us health workers, the frustrations that we express. So it was my turn to be on the other side effectively. Please go to the next slide. I really struggled throughout my internship and my community service. My community service year was in 2020, and as we all know, that was the year of COVID-19. I continued to advocate because, of course, I had gotten TB from the exposure on the front lines, and I basically wanted everyone to understand that we have to do things like infection prevention and control within our hospital. But anyway, I did a lot of advocacy over those years, a lot of articles, a lot of newspaper articles, a lot of online articles on the radio, on the TV. It was just a lot, but a lot of what I was trying to do was to call attention to the front lines. Please go to the next slide. I experienced a lot of problems as a health worker. And I don't know if we have any health workers in the room, but I think those who do clinical work will tell you that it's quite hectic. And yeah, 2020, I had a car accident after a 36-hour shift, and I still live with that chronic back pain. I was anxious, I was depressed, I was constipated, I was frustrated. There was a lot going on. I had brain fog, I was losing my confidence, my memory was failing me, and I just realized that this isn't my life. You know, I can't do this. I can't, be within this health system and look after myself. I felt like I was losing myself. And so I made the decision to leave. Please go to the next slide. Leaving clinical medicine was not an easy decision. And yeah, I left and I told myself, look, the experience that I have in the TB world has to just carry me through. And indeed, it did carry me through. Fortunately, I applied for a position at the Africa Health Research Institute, and I was there. I worked as a clinical research fellow. I was also awarded the Fogarty Global Health Fellowship, which was a one-year fellowship that was basically to support me doing my research and learning how to do the research. And actually, we published a paper at the end of that around subclinical TB, which was mentioned by our previous speaker, the TB that has no symptoms. So then I really got a sense of what it was like to be a researcher. I got the information of the frustrations with the funding and, all the different academics in the unit. And, yeah, I was in another paper around sort of leaving clinical medicine, learning to rest and healing myself. Johnson & Johnson covered my story. And then also there was the TB conference that happens in Durban that I'd been attending for years as a patient or as an activist. And finally, I was invited sort of in my medical role now to come and speak. And that was amazing to speak there, actually. That year, I also spoke to the Royals. I think it was William and Kate. And yeah, we were just talking about my work in TB, as well as, health workers and the issues that we have. But it was just so amazing, again, to see what this really dark period of my life, what it actually became, years later. And the fact that, I could use my voice and I could use my story to actually make changes, in the TB world. And my whole thing was around the fact that pills are not enough. Pills are not enough. Treatment is not enough. What is being done to actually support us through this? Because I had a really, really rough go. And if it wasn't for the networks that I made, if it wasn't for TB Proof and the rest of the advocacy word, that ability to connect with other individuals and that ability to express myself, it really saved me, So please go to the next slide. Then I left RE and I found myself at the Wits Health Consortium Clinical Health Research Unit, CHRU. And there I was working as a project manager in the recruitment and the retention department. Again, another angle to this TB world, coming to understand, the nitty-gritties of clinical trials, how it works, what each department does. And it was just amazing to be in the department that I was in, because I was basically, they were dealing with people who were sick, and I was there to see how that was navigated and how it affected the health workers as well. And while I was there, I won an award as well. I went, some of, the pictures there in the middle is of the award. And then I also helped TB Proof to organize a World AIDS Day event. So that was another, I guess, different aspect of the TB world that I was getting to explore. Please go to the next slide. And then after that, I found myself an unemployed health worker. And I know I spent times, a few months at a time, unemployed in between those last few sort of seasons of my life. But this was the longest season of unemployment. And it was a time where there were protests. And so I joined the protest. I was invited to the Skull World Forum in the UK at Oxford. And I took our story there as unemployed health workers. I was also invited to Germany to be part of a program there to speak on my experiences. I also went to Chicago that year as a member of a team. We were writing basically an article, but using social. It was going to be a medical article, but with a big emphasis on the social issues. And then I started working with TB HIV Care, which is an NGO. And as part of them, I was part of a radio campaign. And this radio campaign was amazing. We worked with local radio stations in the Eastern Cape. And essentially, I was sharing my story, and there was a question and answer session, and people could ask me questions as a TB survivor and as a doctor. So that was quite amazing. It was cut short because Donald Trump made his decision. So I also then again found myself unemployed, but that was quite a big year. At the Oxford, at the Skull World Forum, I even met the Clooneys and George. Like after I spoke, George came up to me and he was like, "How am I supposed to speak after that?" And I was like, "You better work, George." So it was just amazing that this TB that almost killed me just kept taking me to all these different stages, Next slide, please. This slide is, last year I found myself working at Walter Sisulu University as a lecturer and a researcher. So again, another aspect of the TB world. I was lecturing medical students, and what I want to mention about this period is it was so amazing because the students I was speaking to and teaching, we weren't teaching anything about TB, but I brought my story into that room, to warn the students that when we get into the clinical field, it is your responsibility to look after yourself, to find the nearest respirator, to make sure any patients that are coughing are put to the side. And I think it was amazing for them to meet a young brown woman lecturer who had TB and is so willing to share her story, That year, my story was also covered by the Gates Foundation, and I also attended the G20 Health Working Group meeting, which, again, big platforms, and all because of the TB, and what I chose to do with the TB. So please go to the next slide. I am closing off now. So I was asked, as a part of putting this whole together, what does and doesn't work in shifting public perceptions of TB. So what doesn't work is the use of fear-based tactics. We saw those fear-based tactics being employed the whole of COVID-19, and I was really upset because you can't make people change their perception by making them afraid. Making them afraid hijacks their brain. It makes them make completely weird decisions, So instead of using fear-based tactics, what I've been using in these last 14 years is an educational tone, is an empowering tone, an empathetic tone, a tone that understands. So hence, humanizing TB. Another thing that doesn't work is letting the science and the funders lead. Unfortunately, in this whole journey of mine, I recognize that we as affected communities, we are consulted sometimes, but we are not allowed to lead, and we're not allowed to set the priorities. And I thought this is interesting. This year's Stop TB theme is, yes, we can end TB, led by countries, powered by people. And when you say powered by people, I feel that it should be the affected communities that are leading the way, that are deciding the priorities. Yes, we can get support and assistance from the people in science and the people in funding, but in order for us to make a real change, people of the world, we need to be involving and letting the affected communities lead. Next slide. And so our lived experiences truly are a tool to foster understanding and reduce stigma. And why I say this is because my story and my use of my story has shown me that our lived experiences truly can foster this understanding. Because I find things that I was talking about 14 years ago, there was no social support. But now we've got grants that people are getting. You know, there's a change. Now people understand the importance of our diet, you know. So there's a critical need for better engagement with affected communities. We need to let communities lead. Please include us in every step of the way. And it's important to support all TB survivor-led initiatives. And I just wanted to throw mine out there that on this World TB Day, I will be launching sort of specialized TB counseling and support services as someone who's had TB and as a medical practitioner, you know. And I believe that together we have everything we need. So I'm calling out to every single one of you here and anyone you know. I'm looking for any kind of support, collaborators, investors, donations, clients, whatever. But I realized that I would have died without the support that I got. The community, the TB community saved my life. And I would love to continue to be part of that community to affect other people. I mean, part of that community to support other people. Last slide is just a thank you. Please do get in touch. Thank you all so much for, giving me another platform to share my story.
Thank you, Dr. Zolelwa, for that story. Thanks for sharing with us. We now move on to our last speaker for today, which is Russell Rensburg.
Do my stories here. Good afternoon, everybody, and thank you to the speakers that went before me. My name is Russell Rensburg. I'm neither a medical doctor nor a TB survivor, but what I am is a health activist. And I think the theme for this year's talk really resonated, particularly around the work that we've been doing for the last couple of years in trying to make TB visible in a different way. So in just a few days or a week from now, we will celebrate World TB Day, as we do every year. It's a moment when we often restate the familiar refrains or truths that TB is preventable, treatable, and curable. All of that we know to be true. Right? Let me just navigate my way through here. But if we're honest, the reason TB remains a challenge in South Africa and South Africa's leading infectious disease killer is not a lack of biomedical tools. We lead the world in a lot of biomedical tools. We have the best diagnostic assays. Where 65% of the world's TB diagnosis is still done by smear. We are using the best available technology, right? Nor is it the lack of policy intent. South Africa provides significant leadership. This TB think tank is a close collaboration between the National Department of Health TB program and TB scientists, right? But it's probably, and it's because too many people are still being lost along the TB care pathway. TB is not experienced as a diagnosis. It is experienced as a journey through the system over time. It's shaped by access, continuity, and trust. And if we want to change TB outcomes, we need to understand and design for the journey that patients will take. TB care unfolds over time. It begins at home, right, with a cough, right, that lingers, with fatigue that interferes with work, and with decisions shaped by income, distance, and stigma. From there, people move or fail to move through a sequence of testing, diagnosis, treatment, initiation, months of adherence, and eventually a return to everyday life. Sometimes. At each step, people can be delayed or lost, not because TB is clinically complex, which it is, but because community of care is structurally fragile, or continuity of care is structurally fragile. I want to tell you briefly, like drawing from Dr. Zoe's earlier story, right, around her own experience as a TB survivor. I want to tell you briefly about a man I will call Tabo. Tabo delayed going to the clinic because missing work meant losing income. When he did go, TB was not suspected immediately. By the time he was tested, he was seriously ill and needed hospital care. Almost 30% of TB diagnoses are made in hospital, often at late advanced stages of disease. But treatment saved his life. But what helped him finish his treatment was support back in the community from someone who understood the journey and helped him navigate the system. Tabo's story shows us something really important, that TB care doesn't fail all at once. It fails in steps and succeeds only when continuity holds. Well, I think Candy Day was the one that coined it, without good data, you can't have good governance. And over the last couple of years, we've been developing, as the TB Accountability Consortium, we have released an annual state of TB. This year, it's a critical point in South Africa's fight against TB, but it's also an opportunity for us to launch a new set of intelligence that can allow us to have a better understanding of how the patient pathway both succeeds and failed. Right? The 2026 State of TB report in South Africa and the National TB Dashboard mark a very important turning point. For the first time, TB data in South Africa is public, it's timely, it's disaggregated, and usable by actors outside of the state. This was quite a significant achievement. This is a structural shift of how we approach TB, not just a technical one. In a way, the dashboard democratizes TB data and TB knowledge. It collapses the distance between communities and parliament, between lived experience and legislative oversight. This is no small achievement, and I think we should applaud the authorities for agreeing to do this, and particularly our partners at the NICD, who have been at the front line of developing this dashboard. And what we're learning is that the early signals matter. TB testing has increased since the dashboard's launch, partly not just as a result of the dashboard, but also through improved implementation of the targeted universal TB testing approach, which was highlighted in the first presentation. But the real value of the dashboard is not in the aggregate numbers. It is in what it reveals, where the TB pathway is either working or breaking. An interesting insight for us, for instance, was that women are tested far more frequently than men. Yet men account for the majority of TB cases and deaths. Working age men carry the highest burden while having the lowest testing coverage. This is not really a behavioral mystery. It is a pathway design problem that isn't susceptible or acceptable to the men that we need to test. The dashboard allows us to ask better questions as activists, as politicians, as researchers even, and where testing gains are made and where they are stagnating, which provinces and which districts are advancing, and which need more support to achieve their targets. Again, good data, good governance, good action. Who's being tested? It's not just an opportunity on who is not. You know, often we'll get caught up in our performance against data rather than the gems of information that lies underneath that target, like the amount of men who test, the yield amongst men, the age stratification of TB testing, as well as TB results. And all of these provide useful opportunities to look at TB beyond from the supply side approaches, but also to improve our understanding of the patient pathways and where they break or where they succeed. But these questions are not abstract. They are fundamental to whether we succeed or fail in changing the trajectory of TB in South Africa. Data has the power to illuminate blind spots. It can expose inequities. It can expose inequities, right? That averages conceal. It can change and challenge assumptions that have gone untested for years, and it can force us to confront uncomfortable truths about the populations the health system continues to miss. The dashboards also strengthen the hands of advocates like ourselves at the entry level of the TB response. Through the TB Accountability Consortiums, TB survivors have been trained as community activists. For these grassroots advocates and TB survivors working in communities, they can now combine lived experience with public data. The data provides validation and direction. It strengthens storytelling with evidence. It allows lived experience to be paired with concrete proof of where services are failing or succeeding. When a community advocate encourages someone to test, they're no longer acting in isolation. They are part of a broader data-informed effort to close gap that the dashboard has made visible. When they engage districts and facilities, they shift accountability from anecdote to evidence. For civil society organizations engaging provincial departments of health who deliver the care, the dashboard provides a common reference point. It allows conversations to move beyond anecdote and denial towards shared facts and accountability. For TB champions and activists, data becomes a tool not just for critique, but for constructive engagement. It also matters for high-level advocates like TB legislators who are part of caucuses. At the national level, the dashboard plays an equally critical role. Policymakers, legislators, and parliamentary oversight committees cannot meaningfully exercise their mandate without a clear understanding of how and where the TB epidemic is evolving. The dashboard enables parliamentarians to ask sharper questions, to track progress and against commitments, to hold the executive accountable not only for the policy promises, but for the outcomes. This World TB Day is a moment for us to recommit, not only to ending TB, but to building health systems that can hold people in care over time. If we can make that pathway work for TB, we can make it work everywhere else. Thank you very much for the opportunity to share our story. Over.
Thank you so much, Russell, for your presentation. Another thank you to all our speakers today. If you do have a question or comment for any of our speakers, please do raise your hand. I did see, Mamote, that you had a question for Leisha. Could you please speak to your question, Mamote? You may unmute.
Good afternoon, colleagues, and thank you so much, Nolwazi, for organizing this. Thank you to the amazing speakers that we've just had. Yeah, I'm just so motivated. I'm an advocate myself and a clinician, and yeah, it's just exciting to see how much it's being done, and also just how much people are advocating for this disease that is preventable and also curable. So just my questions are really directed towards Leisha. I think you spoke about the TAD and the TAD Plus, and I just had a few questions on the TAD Plus to say, how was the IPC issues addressed for the tongue swabs that were done in the facility? And then secondly, you just stressed the issue of data integration into systems. And I know that often we do things, but if we don't actually report about what we have done, often we miss monitoring the effects of what the interventions have. And I was just wondering whether, how the tongue swab data was actually integrated into the whole system through existing data collection tools like your TB ID register. Over. Thanks.
Thank you so much for your question. So first of all, the TAT Plus study, it was done under strict study research conditions. So with the patients that came through, they were indicated that yes, there will be a sputum collection done through the facility itself. But from the study staff themselves, they were doing the tongue swab, and that's through consenting these patients from the word go. So we made it very clear that there were not going to be any intervention with regards to that's based on the result of the tongue swab. It was purely on the sputum, because we wanted to know what was the yield on the tongue swab. So we were evaluating the tongue swab specifically, but also comparing it to the sputum that was collected under routine care. And should there be any discordance between the two results for the tongue swab and the the sputum, we will then follow them up and make sure that it's acted, the facility acts on the tongue swab, on the sputum result, and not on the tongue swab as such. When it comes to data integration, so we did not integrate the result of the tongue swab within this. It was mainly the sputum collection. Tongue swab was for research purpose only. I don't know if I've answered all of your questions, or is there anything else?
Can I go in again, Nolwazi?
Very briefly.
Yes.
Yes.
So perhaps if you can maybe just from what you have learned, what are some of the practical advices? I mean, you can just respond on the chat. What are some of the practical advices that you would, recommend that we do if we're looking towards, I mean, tongue swabs are definitely, something that is, coming very soon. Just to say, what are some of the things that you would recommend in terms of integration, especially data integration from your experience with working in the facilities? Thanks.
Okay, thank you. Short and sweet. First of all, I just want to say integration. Yeah, data integration is very important. But what I've also learned specifically from a patient point of view is that because it's something new, the patients tend to be a little bit more skeptical. We have done some qualitative research also, and I can share. We are busy writing that up. What the patients have thought about the actual tongue swab, but currently, there are already, I will say, registers and like the dashboard that previous speakers spoken about, that you can integrate the data there. But I just think that there should be, because of the place where the tongue swab actually falls, and I don't know if you've seen in one of the slides that I've shown what was the incremental yield and the relative yield on the tongue swab. There is a specific place where it actually comes in. So tongue swab will be specifically for those that are unable to produce a sputum. That is where we will look at the tongue swab specifically. And so it won't be for all of the participants, but it will be especially those asymptomatic patients that are unable to produce a sputum. So it will be an additional, it won't be like the gold standard for now. It will be an additional. Thank you.
Thank you so much, Leisha. Penny, you may unmute and go ahead.
All right, thank you. Hi, thank you to all the speakers and also to TB Think Tank for providing such an awesome platform. So my comment basically it's more on particularly inspired by great work in advocacy with lived experience sharing. So Zolelwa, for example, I really appreciate the work that you guys are doing. And obviously a platform like TB Think Tank is amazing, but we see less of these opportunities in learning environments. Particularly I'm in a TB Center for Research where it's largely academic by setting. And I think we tend to forget the importance of lived experiences and as well as advocacy at activism level. So I don't know if you think there's a way of integrating sort of this kind of advocacy into learning systems that are more incorporated in, for example, at RE, if we had such positions that would actually enable such partnerships. Thank you.
Dr. Zoe, I think the question was for you.
Oh, it was a question. Hello, hi. Thank you so much for the comment. And I think I don't have an answer. I think we should just talk. We need to speak. We need to continue to engage because I think it is, I mean, I've been to a few sessions where I've spoken and it was, just academics and loved it. It was great. But one of the academics even asked after I spoke, is there anybody here who's ever met someone who's got TB or who deals with people? And I think out of that room of like 100 people, I think 3 people picked up their hands. And so I think there is a big need for that. I think there is a big need to to also have people with lived experiences on board and not just sort of consult them every now and then, but to actually bring them in and to make them because I also really benefited from understanding all of the different systems and how they come together, So I think it would be a great initiative to bring in, even in academic settings, to bring in those with lived experiences and include them and give them opportunities to share and opportunities for people to reach out to them, whenever they're dealing with, because as a health worker, I also had challenges, so it always helps to have somebody with that lived experience to actually be like, oh, this is what's happening. I mean, for instance, still as a medical student, there were issues, there was a patient that some of the doctors that I was in the firm were dealing with, and everybody was just frustrated. And this patient basically had a drip and they were giving them the injectable through the drip. So when they came to speak to me, I was like, of course, I would pull it out too. That thing burns, and that just helped all the doctors in the room to actually just calm down, to understand that, look, she's not just trying to be difficult. What you are asking her to do is really hard, So I think there's a big need. And I think there are also issues like that within academia, that really somebody with a lived experience can give those answers, Yeah.
Thank you so much, Dr. Zoe. And because we are behind time, Chris, you are our last question for today. Please go ahead, unmute and go ahead, Chris.
Good afternoon, and thanks for the excellent presentation. Dr. Zolelwa, I think your presentation was excellent. I just want to find out that also the work around the stigma, particularly when you are experiencing TB at the first hand and in the spaces where you find yourself. Was it part, and I think part of your presentation have spoken to the stigma driver. And the second part of my question is that I think it's excellent that we have these narratives available, but at the community level, do we have like a set standard or guide which we can then provide that to your TB survivors, then to collect that information and start to also tell the stories in different formats and different ways? Thank you.
Thank you for the question. I think that is actually an excellent idea, what you're talking about, a guide that is present at community level. I don't know if that exists, but I think that would be actually a brilliant idea. So people can understand. But I think someone, who's more on the ground level could probably answer that question a lot better than I can. And then when it comes to stigma, so I did face a bit of stigma sort of in my own personal journey when I had the TB. I know, where I was, the res that I was in, I know that there were people that were just like, oh no, like, what did she do wrong? Like, we're all in the hospital. So how does she get sick and nobody else gets sick? And also the stories of other people, other medical students that had TB were only shared with me after I got the TB. So it was like this weird, But as part of TB Proof, we created, there was something called Unmasked Stigma, which was quite a big thing that we did, attacking stigma. And that's why, we also did, as part of TB Proof, some studies. And that was the study why I was at the TB conference, is that I was presenting some findings of that study, of the different kinds of stigma and how they impact patients at different levels of care, sort of when people are taking treatment and when they, so yes.
Thank you. Russell, quickly jump in.
Yeah, no, I probably just want to come with some closing remarks. I think sometimes the best way to deal with stigma is to bring issues into the light, right? And I think one of the things that the dashboard does do, it asks different questions of us as researchers and implementers, right? It asks us if we are willing to be led by the data or by or how interesting a question is on what subclinical TB and the like. Each year still over 54,000 people die from tuberculosis. These are people, the more than half of them are people living with HIV, but close to half of them are people that don't. And I think when we start looking at the dashboard data, we can think beyond just the supply side interventions of how we design facilities, but also about how we target and engage communities who are living with this disease, who make through the inverse care law that those that need the care the most are the least likely to receive it. And then also the importance of continuity of care. That is not an episodic thing that's going to be solved by a new diagnostic tool, because we have great ones. It's not an issue that's going to be solved with shorter regimens if the people that need to be tested and put into care are not being reached. So I want to leave you with this remark, is that let us start thinking about TB more holistically. Let's see how it's integrated into primary healthcare systems, and let the data provide us with a guide of how we engage communities. Because I think a lot of the time we talk about engaging communities, not realizing that for communities to mobilize, they also need to be funded, something that they currently are not. That's not being done. So I think those are my closing remarks. And again, thank you very, very much for the opportunity for us to share. And you can access our TB think tank or our TB dashboard or state of TB publication in the next couple of days on our website at www.rhap.org.za. And we will also share it with members of the TB think tank. Thank you, and over.
Thank you so much, Russell, especially also for tying it up at the end. And thanks to our speakers for allowing us. Thank you so much. Thank you to our speakers and thank you to our attendees. And just a quick reminder of our upcoming conference, not but the South African TB conference coming up in June, which will be held in Gauteng this year. Just a reminder on that. Please do register before the deadline. Lynette, would you like to quickly speak, or was that a mistake? Okay, I'll assume it was a mistake. Thanks again to everyone. Apologies for going over time, and enjoy the rest of your day. Bye.
Thank you. Bye.
Thank you. Bye.
Thank you. Bye.
Bye.
Thank you. Bye, everyone.